Hi, so I'm Lauren Waterman. I am MD Res student at King's College London, supervised by Shah Noram, Vishal Bavsa, and a variety of excellent experts and experts by experience who've been very helpful. Sorry. So my study is on immigration detention centres. So immigration detention centres in the UK are called immigration removal centres, or for short we call them IRCs. And they detain migrants while they await deportation or permission to stay in the country. The UK detains 3 times more people in immigration detention than any European country. And there have been plans by the government put in place to further expand immigration detention. And there's already convincing evidence that being detained in these centres has serious mental health consequences for asylum seekers and other migrants. These are people who are already vulnerable to mental illness and who have complex physical health needs. And findings from long-term studies also show that the negative effects continue long after release from detention. And at the moment, around 90% of people in detention are eventually released back into the community, so they're not actually deported. And there have also been concerns about the healthcare that this group received during and after detention and the processes to keep them safe. One such concern is with a process called Rule 35. Rule 35 is a process whereby doctors in the IRC, particularly GPs, conduct assessments and then raise concerns via Rule 35 reports to the Home Office about detained people who they believe are particularly vulnerable to the negative health impacts of detention, such as those who have a history of being tortured or those who have serious health issues that are likely to deteriorate in detention or have already deteriorated. And this is supposed to trigger a Home Office review within 48 hours of them continuing in detention and further consideration about releasing them. But the Rule 35 process has repeatedly been shown to be unfit for purpose, with significant delays in the process, IRC doctors not understanding the process fully and not receiving any training on it, poor quality reports that don't result in release of vulnerable individuals, and also often not completing reports when they should be. However, research and external audit or service evaluation within immigration detention centres in the UK is usually unfeasible due to significant red tape that has previously prevented research. So under an NHS honorary contract, I was fortunate to be granted access to all the healthcare records at Heathrow Immigration Detention Centre, which encompasses 2 of the largest UK IRCs, including the largest one in Europe. And this was a unique opportunity to conduct a project that NGOs and researchers have previously been prevented from undertaking. The data set I gained access to was vast, which with almost all healthcare records existing as coded data, meaning that many questions could be answered using it. I've been collaborating with a large group of stakeholders, including healthcare service providers, frontline staff, relevant NGOs and experts by experience, who together suggested numerous helpful research questions that could be answered using the data. So as you can imagine, it took quite a while to actually narrow down the focus of my MD Res, but with the support of my supervisors, I've chosen some areas of focus. Currently, my research aim, overarching research aim, is to explore the mental health need within UK immigration centre populations and how the system recognises and responds to this through the Rule 35 process. So key questions to this include: how does immigration detention affect the mental health of those detained? What are the demographic characteristics of the IRC population? What are the mental and physical health characteristics of the population and their reported experiences of torture? And as usual, stratifying by sex is quite important. And what proportion of the population receives a Rule 35 report? How does this vary according to their socio-demographic characteristics and their health characteristics and their reported experience of torture? And finally, what patient factors and service factors predict time to medical assessment for Rule 35 for individuals that have received a referral? The So my methods involve an analysis of routinely collected data from the IRC healthcare records at Heathrow, and an inclusive, thorough, systematic review of primary research articles on the mental health consequences of detention. So going into the methods for the healthcare records study in more detail, they involve a descriptive analysis characterising the socio-demographic and health characteristics of the 24,500 patients during the three-year period I'm looking at. An analysis of the likelihood of patients receiving a Rule 35 referral and how this varies according to their characteristics. Creation of a Cox regression model to assess which patient and service factors predict time to medical assessment for Rule 35. A thorough notes audit of 35 of the patients who have, and this sample was chosen based on people who've both been referred for a Rule 35 assessment and have a history of mental health problems, so that I'm looking at both kind of populations in the more detailed audit. And also collaboration and a very sort of detailed blended engagement with stakeholders, including experts by experience at every stage. And then simultaneous investigation of issues and implementation of solutions. So research outputs will include design and delivery of a training package, which I'll go on to later, to improve care based on the project findings. I won't go too much detail into the systematic review just because of time, but the title is How Does Immigration Detention Contribute Towards Psychological Symptoms, Distress and Mental Illness in Migrants? And it will involve a thematic synthesis. I've chosen quite a comprehensive and broad search strategy, and including grey literature, to ensure that this sort of underrepresented population has their voice included as much as possible. And we'll be using sort of second researchers and third researchers during the data extraction, quality assessment, and data synthesis. So in terms of progress so far, I was successful in obtaining a small grant of just under £4,000 from Royal College of Physicians of Edinburgh. Ben & Jerry's Foundation, I applied to them for funding, and they've indicated that they're likely to fund the dissemination activities once I get onto those. I applied for an NIHR Research for Patient Benefit grant of £150,000 to enable myself to work full-time on the research. Unfortunately, it got to the very final stage and it was rejected, but I was the lead applicant, so it was an extremely useful experience where I developed key grant writing and research design skills. And then I was successful in being awarded a year-long population health fellowship part-time, which finished a year ago, and that gave me training and protected time to develop my public health skills, which are transferable skills to this. And now I am doing a clinical job where I was able to negotiate 2 days a week to work on my MD-Res project. So we've been collaborating with experts by experience who've previously been detained in IRCs. For example, I held a 2-hour meeting with 6 experts by experience. And I've been working very closely with one called Mishka Pillay, who was a co-applicant on the NIHR grant, and I co-author pretty much all of my articles with him, which I think adds a lot to the content. This is a project whose success and impact rests upon the strength of the collaborations with stakeholders. So I've spent time fostering important relationships with a variety of stakeholders, including the healthcare staff and clinical leads in the IRCs, charity leads, the Independent Chief Inspector of Borders and Immigration, and other experts in the field. I've been developing my expertise regarding the IRC healthcare system and the mental health of migrants by attending conferences, webinars, and meetings. I've also demonstrated this expertise by presenting at national and regional conferences and training events on access to healthcare for migrants, and I've published 17 articles during my MD-Res time so far in high-impact peer-reviewed journals, of which I was first author on 14, and 8 of these were letters and editorials published in the BMJ, which goes out to most doctors in the UK. I've also developed and demonstrated my expertise by being consulted as an expert by the Independent Chief Inspector of Borders and Immigration, and by the Detention Centre healthcare team, and being part of the Royal College of Psychiatrists Working Group for Mental Health and Forced Migration. And I've also gained research and editorial experience by being one of the editors of the British Journal of Psychiatry Bulletin. I've attended several courses at King's and UCL, including on academic writing and costings, creating impact engagement, and also the training from my population health fellowship modules. And in terms of the systematic review, I've completed the systematic search and abstract screen, but this will need updating because I had to park it when I gained access after several years of trying to the healthcare records before I would lose that access. So I'll need to update that search, and it's registered on Postpro, and I've also written in detail about my methodology for my thesis. And in terms of the study on IRC healthcare records, I obtained governmental clearances and honorary contract with the NHS trusts, collected the large amount of data into Excel and now into Stata, and have begun analysis. I completed the in-depth evaluation of the 35 patient records, and also conducted sort of informal interviews and information gathering from a variety of healthcare staff and providers. And based on initial findings, I've already begun recommending, designing and implementing service improvements accordingly, which I'll speak about shortly. Here are just some very brief findings from the in-depth evaluation of the 35 records. So these, as I say, were chosen at random based on having a history of being tortured, being referred for a Rule 35 assessment, and also taking medication for mental health problems. The mean length of stay for this group was 96 days, somewhere between 3 and 368. 20 out of the 35 had been detained for more than 28 days. This is actually the only country in Europe to not have a 28-day maximum time for immigration detention. 9 of the 35 had been transferred directly from another IRC or prison. 2 had arrived on small boats across the English Channel. 14 were non-English speakers. 12 out of 35 had been referred for but had never actually received a Rule 35 assessment and report. And for the 13 that had received a report, meant to be 23, who had received a report, the mean time from start of detention to report was 41 days, so quite a significant delay, up to 165 days.
Lauren, we're going to have to wrap up fairly soon because the room is shutting at 1.
Okay, sure. Yeah. So some initial analysis results from the large data sets. 16% had reported being tortured. So I was just going into some of the interventions that I put into place, including I designed and delivered a training day for the GPs and other clinical staff at 4 out of the 5 largest UK IRCs, which was the content of which was based on my preliminary findings, and which was repeated, and national rollout is being planned. That was just about kind of my challenges and my timeline going forward. So I didn't get a chance to go through it all.